Yes.
Hello, actually, yes, CK, we can start with our sessions for Allah.
Yes,
Maybe
I'd
we
like
can.
to introduce the very next speaker, Dr. Ala Uwais from Jordan. He's currently an assistant professor at the University of Muta in Jeddah, Jordan. He completed his A-Page MIS fellowship at the famous Changpeng Memorial Hospital in Taiwan under the renowned mentorship of Professor Li Qidong. And we all know Allah very well. He's a very popular and up-and-coming star in YAG, and is well invited to many conferences and invited faculty in his workshops. And we enjoy his company all the time whenever we meet up for international conferences. And today, Allah is going to show us his experience in repairing caesarean scar defect from the vaginal approach. So Allah, the stage is all yours.
Thanks for your introduction, CK. And I'm lucky that I'm the only one you presented him this time. Okay. Today, I will talk about my experience in caesarean scar defect repair. I already did more than 6 cases vaginally, and I believe it was a successful experience. So as we can see, as everybody knows, this how does caesarean scar defect looks like by MRI image. So what is caesarean scar defect? It's a fluid pouch-like defect in the anterior wall, in the anterior uterine wall at the site of the prior caesarean section, and range in prevalence between papers between 19 to 84. I believe this recognition according to how the obstetrician, how the gynecologist believe in this defect, let's say. So for me, I always try to search for this defect in the patients with the previous caesarean scar. And it's also known as ismocele and niche. So first describe, I researched in history, there was one description in 1974, but the first real description was in 1995 by a series of 51 hysterectomy specimen was studied to define the pathological changes that are present in the area of post-caesarean section. And this man, Morris, he did a retrospective analysis for the symptoms which led to hysterectomy. So what are the main symptoms? The most frequent complaint related to intermittent postmenstrual bleeding. And most of my patients was IVF candidate. So during embryo transfer, we notice a blood at the ET catheter. So we cancel the ET at that time because of blood, and this will decrease the implantation, as we believe that this will decrease the implantation rate. So the 6 cases I did have a previous history of IVF failure, not post-menstrual bleeding actually. Several authors has described ismocele as a cause of infertility, stating that the accumulation of blood will affect the sperm motility and implantation. Professor Wang, he's one of the famous professors in Changpeng Memorial Hospital, found a significant relationship among dysmenorrhea and the width of the defect and the abnormal bleeding. So what are the main imaging we use? Actually, I use vaginal ultrasound, but I always prefer to confirm with MRI image, especially if the patient is insured. Many published articles, especially after 2002, published about surgical approach. Most of it you can find hysteroscopic, laparoscopic, and vaginal, and a little bit laparotomy. Actually, there are few papers published about vaginal approach. The first paper I found was published in 2005. There was a description about combined laparoscopic and vaginal repair. It was 5 cases. Another published paper by a hospital in Shanghai, we all know, I forget the name. They published about a series of cases and their outcome. And another one which compare between laparoscopic and vaginal approach, and one video article published in Fertility Sterility Journal. So in comparison, the two articles I've read said that the vaginal approach has less operative time, less bleeding, faster recovery, and more cost effective. About the efficiency, I think they were comparable. So now I researched more extensively why this scar developed. I reviewed literature and I found suggested hypothesis. Most papers talk about what increases the risk of developing this scar, mainly recurrent cesarean section, and the other thing is doing the cesarean section on dilated cervix, I mean during labor. Nothing written about how this defect may develop. So I suggested that the cause of the defect is actually muscle retraction. As we all know, during labor, the uterine muscle are contract and retract. So this is suggestive, not proven, but that's what I noticed, that after cesarean section, the uterine wall muscle retracted upward to develop this defect. So from where I get this hypothesis, after two cases of repair, I noticed that there is, angulation at the posterior wall after the repair. This means that after the repair, the uterine wall gets shortened, which means that there is an element of muscle retraction or shortening of the muscle. So after the suturing, you notice that there is a development of angulation. Maybe I guess that the uterine wall gets shortened. Although I always try to reach the edge only while I'm suturing. Okay, so what are the surgical steps? I started always by dilating the cervix up to Higar 12. The first case, when I started dilatation, I was hoping that after dilatation of Higar 12 that my finger will reach, but actually my finger was too big to go inside the cervix. Then I inserted a Foley's catheter inside the cavity and opened the vagina at the level of the cervico-vaginal junction, which this junction is the key element in our operation. I believe that you have to open at this level, although the Chinese paper prefer to open 1 cm below. Then half cm almost. Then I dissect the bladder upward. Usually dissecting the bladder after opening at this level is easy. Don't expect difficulty. Usually the adhesion is above, at the level of the peritoneal fold. Identify the defect by palpation. Most papers use lightening of the hysteroscope to identify the palpation, but actually it's so easy to palpate the defect. Opening the defect and trimming it. Apply interrupted sutures, check the Foley's that's free, and close the vagina. I'll go through these steps shortly. So I dilate the cervix. I realized that dilating the cervix will help me to make there more space for suturing and introduce instruments to identify the cesarean scar defect. I was aiming to introduce my finger, but it was impossible. So then I insert Foley's catheter all through the operation. So this will help me to identify the posterior wall and that I am in the canal. Then, and after the operation, I keep the Foley's catheter to maintain the patency of the cervix. So this is the cervico-vaginal junction. We can easily identify it in a patient at the reproductive age because the vaginal rugae is very clear. The Chinese prefer to open here, but actually this will let you lose the plane of dissection and you will have more bleeding. So I always try to open at this level, and you can identify it easily. Especially, as I said, in the patient at the reproductive age. So after I apply the retractor and the tenaculum, I pull the uterus downward so I can find the junction easily, and I open by my scissor at this level. After opening this, you will go into vesico-uterine space. All of us know this space because we open it during cesarean section while we are developing bladder flap, but in a vice versa, through the abdomen. So we open the vesico-uterine fold, then we go to this vesico-uterine space, which is actually avascular space, and you can dissect the bladder upward easily. Try not to open this peritoneum to avoid contamination between the abdominal cavity and the vagina. So all as possible, try to avoid opening the peritoneum. And then you can identify the defect. I promise you. You just put your index finger or your thumb and you can find the defect. Here, this patient has very thin defect. So you can see here the transdenomination of the blood clot here at the Cesarean scar. Here, it's not that clear that you can see my scissor going up. After I open the defect, I can introduce the scissor through the vagina. Then I do trimming. You can easily know that you open the cavity by noticing the follies. Then start trimming the fibrous edges. Try to remove the endometrium edges. So the edges is covered by endometrium. So we aim not to create endometriosis at the site of the scar. So try to do trimming and trim the edges properly, and this will improve the healing. Be careful while you are trimming at the level of the uterine artery. Most of the cases you can identify the uterine artery insertion during the operation. Okay, apply 4 to 5 interrupted suture. Do the angle first, as we do in the cesarean section. Before tying the suture, check if the catheter free, that you did not took any suture to the posterior wall, so you obliterate the cervical canal. Keep the follies for 3 days. This is my suggestion. I'm not sure about it. To this will keep the patency of the cervix, close the vaginal wall. And I will show you a video. Actually, the recording was not that clear, but I will try. So please excuse me for this not good quality video, but I believe I have to show it to you. Wait. Okay, let's start. So this is 35 years old woman.